So yesterday, like we were discussing the urine analysis, acute kidney injury. Then we have discussed the chronic kidney disease, renal replacement therapy, introduction to the nephrotic syndrome, and then we have discussed the diabetic nephropathy. These are all the topics what we have done yesterday. So today I'll be continuing with the nephrotic syndrome. So in the nephrotic syndrome, what is that we are due with is like minimal change disease. Then we need to discuss the focal segmental glomerulosclerosis. Then we need to discuss membranous glomerulonephritis. So these are the topics which are due in the nephrotic syndrome. Followed by that, we will be discussing the nephritic syndrome, in which we'll be discussing IgA nephropathy, post-streptococcal glomerulonephritis, Goodpasture syndrome, and the remaining topics in that. Followed by that, we will be discussing renal vascular disorders, in which we'll be discussing renal artery stenosis and renal vein thrombosis. And followed by that, like we have the polycystic kidney diseases, right? That is your autosomal dominant polycystic kidney disease. Now, let us start with the minimal change disease. So, minimal change disease, can anyone tell me it is more common in which age group? Right. So, that is commonly seen in children. Right. So, if you take the minimal change disease, as I have said you, it is a form of nephrotic syndrome which is commonly seen in children. And the type of proteinuria is very, very important in these patients. Right? Most common in children. Then this minimal change disease, the type of proteinuria that you will have is the selective proteinuria. And what is that selective proteinuria? That is albuminuria. Whereas in other forms of whereas in other forms of minimal change disease, in other forms of nephrotic syndrome, it is non-selective proteinuria. But whereas in minimal change disease, it is the type of proteinuria that you will have is the albuminuria. And albumin is what? It is the protein which will maintain the oncotic pressure. Now, once the albumin is excreted out, right? Once there is albuminuria in these individuals, like these patients, they develop edema. These patients, they develop edema. So, what will be the classical presentation in the child, right? The child wakes up with puffy eyes, right? Child wakes up with puffy eyes. Now, the edema will not be just confined only to the periorbital area. The edema will not be just confined only to the periorbital area. The edema will slowly progress to the other parts of the body as well. So, the edema will progress to scrotum, right, in a boy, or to the vulva in babies, females. And from there, the edema will progress to the lower limbs, where there will be development of pedal edema. Okay, so this is what is the edema that you will have in patients with the minimal change disease. And because of the edema, that is because of the periorbital edema, because of the edema in the vulva or the scrotum, and as well as the pedal edema, these patients, they will have weight gain. Right, they'll have weight gain. And not only that, because of albuminuria, the fluid will also enter into the third spaces. What are those third spaces where the fluid can enter into? The fluid can enter into the pleural space as well. Once the fluid enters into the pleural space, these patients, they develop bilateral pleural effusion. Now, can anyone tell me what is the most common cause of pleural effusion? Yes. What is the most common cause of the pleural effusion? Any one of you? Not tuberculosis. Tuberculosis is not the most common cause. Very good, Rohita. That is congestive cardiac failure. That is the most common cause for the pleural effusion. Now, if the question is asked like what is the most common cause of exudative type of pleural effusion, then what will be your answer? Exudative, most common cause of exudative. That becomes your infection. That is your tuberculosis. Okay. Does anyone know what is Light's criteria in pleural effusion? What is the Light's criteria used for? Uh, it is like mainly to identify exudative type of pleural effusion. We use the Light's criteria. And can anyone tell me what are the components of the Light's criteria? There are totally 3 components, and out of 3, one should be positive. What are those 3 components in the Light's criteria? The protein levels, the fluid protein level should be more than 3 grams per deciliter. Then the fluid protein to serum protein value should be more than 0.5, and fluid LDH to the serum LDH value should be more than 0.6. So out of these 3 values, at least one should be positive to consider the Light's criteria is positive. And if Light's criteria is positive, it is suggestive of what? It is suggestive of the exudative type of pleural effusion. Okay. And now, in these patients with nephrotic syndrome, what type of pleural effusion you will have? What type of pleural effusion the patients will have? Very good. So it is the transudative type of the pleural effusion. Right, it is the transudative type of the pleural effusion. Okay. Now, the next very important point here is there is also fluid accumulation in the abdominal cavity. Now, because of the fluid accumulation in the abdominal cavity, these patients, they develop ascites. Right, because of the fluid accumulation in the abdominal cavity, they will have ascites. Okay, so ascites is what? Where there is accumulation of the fluid in the peritoneal cavity, and whenever there is ascites, what will happen to the abdominal girth? Right, the abdominal girth is increased. And what will happen to the umbilicus? The umbilicus, it is everted. Right, the umbilicus is everted and the abdominal girth is increased. So that is what you will. And very important point is in these patients with the minimal change disease, they will have normal blood pressure. The blood pressure is not elevated. Whereas in other forms of your nephrotic syndrome, the blood pressure is elevated. Now, how do you work up these patients? Right? Yesterday we were discussing the diabetic nephropathy. What were the glomerular lesions in diabetic nephropathy? Yes. What are the glomerular lesions in diabetic nephropathy? Yeah, you have diffuse and nodular. But which is more common between these two? Diffuse is more common. What is the earliest change in the diffuse? What is the earliest change in the diffuse? Thickening of the glomerular basement membrane, right? But which is pathognomic? Which is pathognomic? That will be nodular. That is nothing but your KW lesions. Similarly, you need to know the workup in the minimal change disease as well. So, because of the renal impairment, the blood urea nitrogen levels, they are elevated. And at the same time, what will happen to the serum creatinine? The serum creatinine is also increased, okay, because of the renal impairment. And in patients with nephrotic syndrome, what did we discuss? The urine microscopic examination will show you the presence of the oval fat bodies. Right, will show you the presence of the oval fat bodies. And what will happen to your 24-hour urinary protein? Right, the 24-hour urinary protein, it is elevated. Okay. And what will happen to the complement levels? This is very important point. That is, the complement levels, they are normal. But what is the investigation of choice? What is the investigation? Right. What is the investigation which tells you that the individual is having minimal change disease form of nephrotic syndrome? So investigation of choice will be the kidney biopsy. Right? The investigation of choice will be the kidney biopsy or the renal biopsy. Now, when you do a renal biopsy, you have to observe that renal biopsy under the light microscopy, electron microscopy, and as well as the fluorescent microscopy. Right? Light microscopy, electron microscopy, and the fluorescent microscopy. So this is what is your the renal biopsy which you have to observe under. You take the light microscopic picture. Light microscopy, there is no abnormality. Right? There is no abnormality observed under the light microscopy. That means you will not be able to find anything. You feel that like it's completely normal. But in electron microscopy, you will notice that there is fusion of the food process. Right? There is fusion of the food process. And why does this fusion of the food process occur? This fusion of the food process occur, that is mainly because of loss of basement membrane polyanion. Right? And what is that basement membrane polyanion? That basement membrane polyanion will be heparon sulfate proteoglycan. Right? Heparon sulfate proteoglycan. That is what will be the electron microscopic features. That is fusion of the food process, and that particular fusion of the food process is mainly because of loss of basement membrane polyanion, that is heparon sulfate, the proteoglycan. Okay. Then you take the fluorescent microscopy. In the fluorescent microscopy, you will notice that there is absence of immunoglobulin and as well as C3. That is what is the light microscopic picture, sorry, the fluorescent microscopic picture in patients with the minimal change disease. Then one point you have to remember is the etiologies or etiopathogenesis is immune hyperreactivity against the glomerulus. Right? It is the immune hyperreactivity against the glomerulus causing glomerulonephritis. Now, what are those various etiologies which will be responsible for the development of the minimal change disease? These etiologies for minimal change disease, we have drugs, then we have infections, then we have some toxins, then we have some tumors. So now first let me tell you the drugs, then followed by that toxins, then you need to know what are the infections that will be responsible for the development of minimal change disease, then followed by that what are the tumors that will cause minimal change disease. You take the drugs, right? And what is that particular group of drugs which will cause renal papillary necrosis? Drugs which will be causing renal papillary necrosis. Anyone? Very good, Jacob. That is NSAIDs. Even they also cause minimal change disease as well. Then the other important is, what is a condition where you will have orange colored urination? Yes, orange colored urination. That is rifampicin. Right? That is rifampicin. You'll have the orange colored urination. Then interferon alpha. Can anyone tell me in which infections we use these interferons? In which infections we use this interferons? Anyone? Yeah. So that is which viral infections? Yeah, that is viral hepatitis. Right. And another important simple antibiotic that we have is ampicillin. And one more important drug which will cause minimal change diseases, trimethadione. Okay. So can anyone tell me what is trimethadione? Yes. What is this trimethadione? Anyone? Trimethadione, it is an anticonvulsant drug. Trimethadione, it is an anticonvulsant drug. Then gold salts. Yes, please tell me where we were using previously the gold salts. Anyone? In which clinical conditions? Very good, Jacob. They were being used in the treatment of rheumatoid arthritis previously. Okay, but presently in rheumatoid arthritis, what is the drug of choice, Jacob? What is the drug of choice now? Methotrexate. Methotrexate. Okay, right. But when you are giving methotrexate to the patient, what is the supplemental drug that you should give along with methotrexate? That is folinic acid. That is leucovorin. Folinic acid should be given. Okay. Now coming to the toxins that will be causing the minimal change disease. The toxins that will be causing minimal change disease will be mercury, right? And then lithium. Okay. What is the endocrine disorder associated with lithium? Endocrine disorder associated with lithium. Anyone? Very good, Jacob. That is nephrogenic diabetes insipidus. That is 1 point. And yes, Vinita and as well as Soumya, correct. That is the hypothyroidism as well. Lithium will also cause hypothyroidism. Then the another important toxin is the bee sting. Even this will cause minimal change disease. Then coming to the infections. So does anyone know what is that particular infection which is considered as the kissing disease? Infection which is considered as the kissing disease. That is infectious mononucleosis, which is caused by Epstein-Barr virus. Right? Infectious mononucleosis, which is caused by Epstein-Barr virus. Coming to the tumors. The tumors that will be causing the minimal change disease is the Hodgkin's lymphoma. Right? That will be Hodgkin's lymphoma. So these are the conditions, right? Or these are all the etiologies which will be causing minimal change disease. Now, what you have to remember and what you have to understand is all these etiologies, they are responsible for immune hyperreactivity. And that will be causing glomerulonephritis. So now what is that we need to do? You need to suppress this immune hyperreactivity. Now, how can you suppress this immune hyperreactivity? This immune hyperreactivity can be suppressed. So now the treatment. So if you see the treatment in these patients, what will be the drug of choice to suppress that immune hyperreactivity? Right? You need to give steroids. Okay. So prednisolone is the drug of choice. Right? And for how many days you need to give this prednisolone and what will be the dosage of the prednisolone? The dosage, it is around 1 to 1.5 milligrams per kg per day. Yeah, Jacob, like, what do you mean to say? You are telling like GN, right? Glomerulonephritis. Are you asking the same? Hmm? Right. See, where exactly is the pathology in your nephrotic syndrome and as well as nephritic syndrome? It is in the glomerulus, right? It is in the glomerulus, right? And what exactly is happening to the glomerulus? It's an inflammation of the glomerulus, right? Or degeneration of the glomerulus, and which we consider it as glomerulonephritis. So all your nephrotic syndrome and nephritic syndrome, the pathology is in the glomerulus, but the type of pathology and pathogenesis is different in various forms of nephrotic and nephritic syndrome. So all of them, they come under your glomerulonephritis itself. Are you understanding this, Jacob? Right? In all of them, you have, when you like when there is hyperreactivity to the glomerulus, there is inflammation of the glomerulus, and that will be, we will be considering it as glomerulonephritis. And why are we giving prednisolone? To reduce the inflammation and to reduce the hyperreactivity. Okay, right. So prednisolone, the dosage is 1 to 1.5 milligrams per kg. This you have to give for 4 weeks, right? And this should be followed by tapering dose. And how much should be the tapering dose? That is, this is like 1 to 1.5 milligram per kg per day. Okay. Whereas the dosage of the prednisolone, it is 1 milligram. That is when you are tapering, it is 1 milligram per kg per day. Okay. That is a dosage of the prednisolone. And this should be given for another 4 weeks. Right. So you should give totally 8 weeks. Right. And once you give this prednisolone, the individual goes into a state of remission, and then you need to taper and completely stop. You need to taper and completely stop. But few patients or few children, they develop or they will have the relapse. Right? Few children, they will have the relapse. Okay. And if the relapse occur, the steroids are given again. Right? If the relapse occurs, the steroids are given again. That that means once you stop steroids, there there is relapse once again. That is why these are called, these patients, they are considered as steroid dependent nephrotic syndrome. Right? That is why these patients, they are considered as steroid dependent nephrotic syndrome. And when these patients like are given steroids for longer time, what is the endocrine abnormality that these patients can develop? Yes, when steroids are given for longer time, what is the endocrine abnormality these patients can develop? Very good, Kiki. So they develop Cushing's, right? They develop Cushing's. Okay. Now, in order to avoid the development of the Cushing's, right? So there is like toxicity with steroids now. When the patient is on long-term steroids, there is development of Cushing's. So in order to avoid this, right? So to reduce the toxicity with steroids, what are the alternative immunosuppressive agents that we need to use? The alternative immunosuppressive agents that we need to use is cyclophosphamide, or we need to give levamisole. Okay, cyclophosphamide or levamisole should be given. That is mainly to reduce the toxicity with steroids. Okay, and overall, how is the prognosis in these patients with minimal change disease? They have good prognosis, right? They have good prognosis. Okay, so this is about the treatment of the Cushing's. And cyclophosphamide is also the drug of choice for steroid resistant nephrotic syndrome or steroid resistant minimal change disease. Patient is not responding to the steroid. So for steroid resistant nephrotic syndrome, what we need to give is cyclophosphamide. Okay. So that completes the discussion of your minimal change disease, right? I hope the same topic might have been discussed even in your pediatrics as well. So this will be a completely a revision part for you, what I'm discussing in the medicine here, because minimal change disease, it is a disease like what you see in children, not in adults at all, right? Next. Now, after having discussed about the minimal change disease, the next important form of the nephrotic syndrome, it is your focal segmental glomerulosclerosis. Now, let me take up the discussion of focal segmental glomerulosclerosis. So once we finish these three, then that is focal segmental glomerulosclerosis and membranous glomerulonephritis, then we will revise the entire nephrotic syndrome once. Focal segmental glomerulosclerosis. So if you take this focal segmental glomerulosclerosis, this is the most common form of nephrotic syndrome in adults, right? Most common cause of nephrotic syndrome in adults. That will be your focal segmental glomerulosclerosis, right? In case of focal segmental glomerulosclerosis, the common renal pattern of injury results from damage to the podocytes. So in focal segmental glomerulosclerosis, the structures which are damaged, they include podocytes. Okay. Now, the damage to the podocytes, either the pathology can be directly in the glomerulus itself, or pathology can be somewhere else or some other etiology causing damage to the podocytes. Accordingly, we classify this focal segmental glomerulosclerosis into two forms. One is primary focal segmental glomerulosclerosis, right? Primary focal segmental glomerulosclerosis is that where the pathology is directly within the kidney itself because of gene mutations. And what will be the gene mutations? I will tell you. And the other one is secondary focal segmental glomerulosclerosis, right? Some other etiology will be damaging the kidney. Now, coming to your primary focal segmental glomerulosclerosis. Primary focal segmental glomerulosclerosis, it is mainly because of abnormality in a collagen. And what will be that collagen which is abnormal? So it is abnormality of hereditary or heritable abnormalities of several podocyte proteins. And because of abnormality in the podocyte proteins, these patients, they develop focal segmental glomerulosclerosis, right? Or there will be abnormality to the underlying type 4 collagen. Okay, so there will be abnormality of the several podocyte proteins, or the abnormality will be to the underlying type 4 collagen, right? That is one important etiopathogenesis for development of primary focal segmental glomerulosclerosis. And another form in the primary FSGS is polymorphisms. Right? Polymorphisms in APOL1 gene. These two, they contribute to your primary FSGS. Then, what are the conditions which will cause the secondary FSGS? The conditions which will cause the secondary FSGS, they include mainly the infections. Okay, I will just write the conditions which are causing secondary FSGS. I will write them separately. We have infections that can contribute to secondary FSGS. And these infections, right, what are they? They include the HIV, right? And the HIV associated infection, we call it as HIVAN. That is called HIV associated nephropathy. I'll be discussing about the HIVAN separately. And along with the HIV, the another important viruses are hepatitis B virus and as well as the human papilloma virus. They can cause the secondary FSGS. So where will be the problem? The problem will be in the podocyte. And then we have drugs which can cause secondary FSGS. And these particular drugs include the heroin nephropathy or the heroin addiction. And next is palmidronate. So can anyone tell me what is palmidronate? Yes, what is palmidronate? Right, very good. So palmidronate, it is the bisphosphonate. Right, palmidronate, it is the bisphosphonate. And next to the drugs, we have some comorbid conditions. What are those comorbidities which can cause secondary FSGS is, number one is your hypertension, and the next one is massive obesity. Right, hypertension and as well as massive obesity. These two, they contribute to the development of your contribute to your focal segmental glomerulosclerosis. Apart from this, we have a genetic disorder of the kidney itself where you can have the development of focal segmental glomerulosclerosis, that is Alport syndrome, and one hematological condition, that is sickle cell disease. Right, that is sickle cell disease. Okay, so these are the etiologies that will be contributing to secondary causes for focal segmental glomerulosclerosis. So in primary, pathology is directly within the kidney, whereas secondary, some other etiology or some other comorbidity will be causing pathology within the kidney. Now, in case of the focal segmental glomerulosclerosis, why are we using this term focal and segmental? Why are we using this particular term focal is because it is only few glomeruli which gets affected, right? And why is it called segmental? Right, it is called segmental because it is only a part of the glomerulus, right? It is only the part of the glomerulus that gets affected. Okay, that is why it is called segmental. So only few glomeruli, that is focal, and only part of the glomerulus is affected, that is segmental. So this is what is called as focal segmental glomerulosclerosis. I'll show you that. You see this. This is the normal glomeruli. N stands for, this is your normal glomeruli. But here you observe this part of the glomerulus, it is sclerosed. Sclerosed in the sense, it is fibrosed. Right, it is fibrosed. Whereas the remaining part of the glomerulus, it is absolutely normal. Now it is only part of the glomerulus is getting fibrosed and sclerosed, and that is the reason why it is called focal segmental glomerulosclerosis, right? Now, what are the other important features that you will have in these patients with the focal segmental glomerulosclerosis is this focal segmental glomerulosclerosis, the another name which is given for this, it is also called as reflux nephropathy. Why? Why is it called reflux nephropathy? Now, can anyone tell me where exactly will be the site of opening of the ureters in the bladder? Anyone? Very good, Jacob. That is in the trigone of the bladder. Okay. And when the ureters are opening into the trigone of the bladder, do you have any sphincters in the ureters at the opening? Do you have any sphincters in the opening of the ureters into the trigone? There is no sphincters. Then when the bladder contracts, how the reflex is prevented? When your detrusor is contracting, how the reflex into the ureter will be prevented? Very good, Jacob. So the ureters, they will have oblique insertion into the trigone of the bladder. And whenever the detrusor, that is your bladder, is contracting, the ureters which are opening obliquely, they get compressed. And thereby the reflux does not occur. Thereby the reflux does not occur. But you know what these all conditions will do? All these, that is infections or drugs or hypertension or your Alport syndrome, or in case of the sickle cell anemia, what the problem can happen, right? What will be the problem? The problem is this particular reflux, whatever is there. Okay. So that reflux, whatever is occurring, that gets disturbed. Why? Because these etiologies, that is secondary FSGS, they cause inflammatory destruction of the ureteric opening into the bladder. Thereby, whenever the bladder contracts, there will be reflux of the urine from the bladder into the ureter. And from the ureter, the urine enters into the kidney. And in the kidney, the urine, there will be stasis. And once there is stasis of the urine, it gets infected, because that will be a seat of infection. That will be the seat of infection, right? And once the urine is infected and once the kidney is infected, that we call it as the pyelonephritis. That we call it as the pyelonephritis. Okay. So whenever there is pyelonephritis, a part of the glomerulus, right, and only few glomeruli, they undergo sclerosis, right? Only a part of the glomerulus and only few glomeruli, they undergo sclerosis. And that we call it as the focal segmental glomerulosclerosis. That we call it as the focal segmental glomerulosclerosis. So it is mainly because of your pyelonephritis, there is accumulation of the fibrous tissue within the glomerulus, because there is an injury first. And after injury to the glomerulus, how does the process of the healing occurs? The process of the healing occurs by accumulation of the fibrous tissue. That will result in focal segmental glomerulosclerosis, right? That you observe in secondary FSGS. But primary FSGS, the problem is directly within the kidney itself, which will induce the focal segmental glomerulosclerosis. So all of you, did you understand this pathogenesis? Just give me a thumbs up if you have understood. If you did not, please let me know. I'll repeat again. All right. Okay, good. Now, so secondary FSGS is usually associated with, what is HUN? You mean to say hemolytic uremic syndrome? What do you mean by the word HUN, Jacob? Yeah, yes. Secondary FSGS, it is usually associated with the hydroureteronephrosis, which is nothing but your enlargement of the kidney and as well as the enlargement of the ureters. That is correct. Now, if you take the clinical features in these patients with the FSGS, these clinical features include the following. Number one, you have to remember and understand that in nephrotic syndrome, usually you will not have hematuria, but this is the exception. FSGS, these patients, they will have hematuria, right? And because of which, what the patient will complain as, the color of the urine, it is cola colored urine, right? The color of the urine will be the cola colored urine, okay? And I said you, all the forms of nephrotic syndrome, they will have hypertension, except for your minimal change disease. So even these patients will develop hypertension, because of which they will have headache. Because of which they'll have headache because of the hypertension. And the proteinuria that you will have is non-selective proteinuria. Right? Non-selective proteinuria. That means along with albumin, even the globulin is also being excreted out. That is non-selective proteinuria. And almost within next 6 to 8 years, these glomerulonephritis will progress and renal failure develops in 50% of patients, right? In next to 6 to 8 years, right? There will be development of renal failure in almost 50% of cases, right? Then I said you, in all the forms of nephrotic syndrome, you'll have dyslipidemia. Even these patients also, they will have the hyperlipidemia, right? In severe cases, they have hyperlipidemia in these patients. And how will be the prognosis in this individual? The prognosis is completely variable. But how was the prognosis in minimal change disease? The prognosis in minimal change disease, like good prognosis. Okay. Yeah, Kamal Nathan, urine output will be reduced. Okay, because of the renal failure, they will have decreased urine output. They will have oliguria. They will have oliguria. Okay, right. Then how will you work up these patients? So in the workup, when you do a kidney function test, the kidney function test will show you that the serum creatinine is elevated. That the serum creatinine is elevated. And when you do a urine microscopic examination, right? Urine microscopic examination will show you a hematuria. When do you call significant hematuria? Yesterday we have discussed urine analysis. Can anyone tell me? When will you call significant hematuria? Or persistent hematuria? Very good, Jacob. So in one sample, right? In one urine sample, if it is more than 100 RBC per high power field, right? Then we consider it as the hematuria. Or like, yes, more than 5 RBCs in 3 samples in 3 subsequent weeks. Then we call it as the hematuria. So urine microscopy, it will be showing more than 100 RBC per high power field in a single sample to consider it as significant hematuria. Then what is the investigation of choice? Right? The investigation of choice will be biopsy. Right? The investigation of choice will be biopsy. And one point you have to remember here is that the lesions, right? The lesions in case of the focal segmental glomerulosclerosis, they are located deep inside, right? The lesions are more pronounced deep. Where are these lesions? These lesions they are present in corticomedullary junction. Right, these lesions, they are present in the corticomedullary junction. Okay, now because the lesions are present in corticomedullary junction, if you do a superficial biopsy, the superficial biopsy will miss the diagnosis, right? So you need to, so superficial biopsy, diagnosis is missed, right? Diagnosis is missed. Okay, so in order to make out these lesions, you need to take a sample from deeper part of the kidneys. You need to take the sample from deeper part of the kidneys, right? And what will be the light microscopic finding? What will be the electron microscopic finding? And what is that you will notice in the fluorescent microscopy? Light microscopy, you will notice that it is only the part of the glomerulus, right? You will notice that it is only the part of the glomerulus is involved, right? And only some segments of glomerulus are involved. That is what you will observe in light microscopy. Whereas you take electron microscopy. In electron microscopy, you will observe the presence of the hyaline deposits, right? Whereas in the electron microscopy, see, basically which cells are affected in these patients, that is podocytes, right? So you will notice that the podocytes, there is effacement of the podocytes, right? There is effacement of the podocytes. And not only effacement, there will be also detachment and as well as vacuolization. Right, detachment and vacuolization. Okay, so that will be the abnormality in the electron microscopy. Then you take in the fluorescent microscopy. In the fluorescent microscopy, you will notice the presence of IgG. Okay, so this is about the biopsy picture in patients with focal segmental glomerulosclerosis. Now, so that is the investigation of choice. That is the investigation of choice in these patients, right? Then, how do you treat these patients? Coming to the treatment of focal segmental glomerulosclerosis. So, in the treatment, very important is all forms of FSGS, they should be given diuretics. Why is that you should give diuretics? See, like whether it is primary FSGS or secondary FSGS, whatever it is, all the forms of FSGS should be given diuretics. And you are giving diuretics mainly for the treatment of the edema, right? And these patients, they also have hypertension. And because of the hypertension, what are the drugs that you should give for hypertension? That is ACE inhibitors. The advantage of the ACE inhibitors is that they will not only reduce the blood pressure, right? So they will control hypertension and they will also control proteinuria, right? They will control hypertension and as well as the proteinuria, both. And the other group of drugs that you should be given in these individuals is because these patients, they're having dyslipidemias. So what are the drugs that you will be given? You'll be giving is, one is statins, and the other group of drugs are the either statins or niacin should be given, right? Either statins or the niacin should be given for controlling of the hyperlipidemia or the dyslipidemia. Okay, so tell me about your niacin. So niacin is required for which form of dyslipidemia? Anyone? Niacin? No, no, no. Not for hypertriglyceridemia. For hypertriglyceridemia, we give fenofibrate and statin. Not for LDL. Niacin, it is mainly given to increase the HDL levels. To increase the HDL. Yeah, so whenever there is low HDL, then we give this particular niacin, right? Very good, Vinita. So that is about like how do you treat this dyslipidemias. Now, you need to give the drugs to suppress the immune reactivity, because your primary FSGS, if you see, right? See, secondary FSGS, they're not causing immune hyperreactivity. What are these secondary FSGS causing? They're causing your hydroureteronephrosis, and thereby there is focal segmental glomerulosclerosis. The immune hyperreactivity is caused by the primary causes, right? What are these primary causes? That is abnormality of the podocyte protein and polymorphism of APOL1 gene. They are the one like which are causing the immune hyperreactivity. So if you see the treatment of primary FSGS, in primary FSGS, the drugs that you should be giving is steroids. Okay, immunosuppressive therapy is very much important. And this particular steroids that we give is the oral prednisolone. Right, and this oral prednisolone, the dosage will be 1 milligram per kg per day. And for how many weeks you have to give this oral prednisolone? You have to give for nearly around 4 to 16 weeks. Right, the oral prednisolone you should give 4 to 16 weeks. And your oral prednisolone should be given only for primary FSGS, not for secondary FSGS. For suppose the primary FSGS, if the individual is steroid resistant, right? If the patient is like steroid resistant, or if the individual is steroid intolerant, right? Steroid resistant or steroid intolerant, then you should give the calcineurin inhibitors. Right, then you should give the calcineurin inhibitors. Example, cyclosporin. Right, or the other alternative drug is mycophenolate mofetil. Right, calcineurin inhibitor cyclosporin or mycophenolate mofetil can be considered. So this is like when the individual is steroid resistant or steroid intolerant. Okay, and if at all, like these patients, they're not responding to any of your immunosuppressive drugs, then you need to plan for the kidney transplantation. Okay, so the other option for the primary FSGS is kidney transplantation. But before doing kidney transplantation, you need to suppress that immune hyperreactivity so that the immune hyperreactivity does not affect the transplanted kidney. So that is the reason why prior to kidney transplantation, you should give plasma exchange therapy, right? Plasma exchange therapy, and possibly rituximab should be given. Right, prior to the transplant surgery, you have to give plasma exchange therapy and as well as the rituximab. Okay, so this is what is the treatment for your primary FSGS. But for secondary FSGS, there is no role of the immunosuppressive therapy at all. For secondary FSGS, what are the causes for secondary FSGS? Infections, drugs, comorbidities like hypertension, massive obesity, then Alports and sickle cell. So you need, for secondary FSGS, you need to treat the underlying cause. Right? You need to treat the underlying cause. Okay. So this is about your focal segmental glomerulosclerosis. Right. So this is about your FSGS. Now we'll move on to the last important form of the nephrotic syndrome, that is membranous glomerulonephritis, the one which is commonly seen in elderly individuals. So membranous glomerulonephritis. So if you take this membranous glomerulonephritis, right, it is most common cause of the nephrotic syndrome in elderly individuals of age group fifth to sixth decade. Right, fifth to sixth decade. And it is immune mediated disease. Right, it is an immune mediated disease which is characterized by accumulation of immune complexes, right, which is characterized by accumulation of the immune complexes in the subepithelial portion of the glomerulus. Right, in subepithelial portion of the glomerular capillary walls, or in subepithelial portion of the glomerulus. Now, so it is like we are discussing that it has an immune complexes. Immune complexes means there should be some antigen, and to this particular antigen, the antibody will be formed. And that particular antigen antibody complex that will be deposited in the subepithelial portion of the glomerulus, resulting in membranous glomerulonephritis. That is what is your immune complex. Now, in this immune complex, what is the antigen? So even your membranous glomerulonephritis also, we have two forms, primary form and as well as the secondary form. right? Primary and as well as the secondary. So you take the primary form. If you take the primary form of the disease, it appears to be you should have an antigen. Now, what is the antigen in the primary form? The antigen in the primary form is phospholipase A2 receptor, right? Phospholipase A2 receptor. That is the antigen in the primary form. And this phospholipase A2 receptor, where is it present? It is present on the podocytes, right? Phospholipase A2 receptors, they, they are present on podocytes in 70 to 80% of patients. Okay, that is what is your primary form, where the antigen is formed against the phospholipase A2 receptor, which is present on podocytes in 70 to 80% of patients, right? Now, that means this is the antigen. Against this particular antigen, the antibody will be formed, and that immune complex will be deposited in the subepithelial portion of the glomerulus, causing membranous glomerulonephritis. Whereas you take secondary form. Secondary form, it is associated with tumors, right? And secondary form, it is associated with certain infections. And secondary form, it is also associated with certain autoimmune conditions, right? Now, what are those secondary forms? And then even certain drugs, they contribute to the development of membranous glomerulonephritis. That is your secondary form, right? And how is the prognosis? The prognosis is completely variable, similar to that of your focal segmental glomerulosclerosis, right? Almost 50% of patients with membranous glomerulonephritis, they progress to end-stage renal disease, right? They progress to end-stage renal disease over 3 to 10 years, right? In a 3 to 10 years period, 50% of patients, they go into a state of the end-stage renal disease. But what are those poor prognostic factors, right? So, okay, I'll come back to that poor prognostic factors once I discuss the entire membranous glomerulonephritis. Right, now let me discuss about the secondary forms. Secondary forms, what did I tell you? Like it is associated with infection, certain autoimmune disorders, certain malignancies, and certain drugs. Now, what are those causes for secondary form of membranous glomerulonephritis? So one important, like what we have discussed, is infection, then followed by that systemic autoimmune diseases, right? Systemic autoimmune diseases, then followed by that neoplasia. Then we have drugs which can contribute. Then we have some miscellaneous conditions. First, you take the infections. Infections, they are mainly the viral infections or viral hepatitis. That is hepatitis B and as well as the hepatitis C. And next is leprosy, right? Then yesterday regarding leprosy, we were discussing one point, right? We use clofazimine in this. So what is the effect of clofazimine in the kidney? Yes, very good, Hari. There will be red color urine. Red color urine. Okay. Next, malaria is another infection which can cause secondary membranous glomerulonephritis. Then schistosomiasis. So what is the name of the fever associated with schistosoma? What is the name of the fever? That is called Katayama fever. Okay. Now, in these individuals, along with RBC in the urine, what are the additional cells that can be seen in the urine? What are the other cells that can be seen in the urine in this schistosomiasis? That is eosinophils. And you also have an egg, right? What is the description of the egg, Jacob? Right, very good, Ritika. So, egg with terminal spine. Egg with terminal spine. Okay. So, viral hepatitis, leprosy, malaria, schistosomiasis, and then syphilis. These are the infections. And next is filariasis. These are the infections that can contribute to your secondary form of membranous glomerulonephritis. Then we have autoimmune diseases. What are these autoimmune diseases? These autoimmune diseases are systemic lupus erythematosus, then rheumatoid arthritis, Sjogren syndrome, then we have Graves, then ankylosing spondylitis, then we have Hashimoto's. Okay, and lastly, myasthenia gravis. Right? So these are the systemic autoimmune diseases which will cause membranous glomerulonephritis. Then we have the neoplasms. These neoplasms, they include, that is carcinoma of breast, carcinoma of colon, and carcinoma of lung, and carcinoma of esophagus. These are the malignancies that can contribute, and followed by the drugs. And the very important is, just now we were discussing about the gold salts. Gold salts will cause which other form of your nephrotic syndrome? Gold salts are associated with which other form of nephrotic syndrome? Minimal change disease. Minimal change disease. Okay. Next, penicillamine. So can anyone tell me where do we use this penicillamine? Yes, we use that in case of Wilson's. Then captopril, which is an AC inhibitor. Then NSAIDs, non-steroidal anti-inflammatory drugs. And then probenecid. Where do we use this probenecid? That is in gout. It is a uricosuric agent. Uricosuric agent. Then we were discussing just now about the trimethadione. So this trimethadione is also associated with which other form of nephrotic syndrome? Yes, minimal change disease. Okay, right. Then miscellaneous causes that will contribute for the development of membranous glomerulonephritis will be sarcoidosis, right, where there will be non-caseating granuloma. Then Guillain-Barré syndrome, right? Then alpha-1 antitrypsin deficiency. Then Fanconi syndrome. Okay, so these are the miscellaneous causes for the development of. You take this Guillain-Barré syndrome. What type of paralysis you will have in Guillain-Barré? Yes. What type of paralysis do you have in Guillain-Barré? Now, ascending paralysis only, but is it like flaccid or the spastic? Right. So the type of paralysis is the flaccid paralysis that you'll have in these individuals. And alpha 1 antitrypsin deficiency is associated with which all pulmonary pathologies? Alpha 1 antitrypsin deficiency is associated with Panasnar emphysema. Very good, Jacob. And one more uh, respiratory pathology, which can be seen in alpha 1 antitrypsin deficiency, apart from Panasnar emphysema. Anyone? Alpha 1 antitrypsin deficiency. Very good, Jacob. Excellent. Yes, Hari, right, good. That is bronchiectasis. What will be the liver pathology in alpha 1 antitrypsin deficiency? Liver pathology in alpha 1 antitrypsin deficiency. Excellent. That is cirrhosis of liver. Okay. Now, these are the etiologies which will be responsible for your membranous glomerulonephritis. And can anyone tell me what is Fanconi syndrome? What is Fanconi syndrome? Anyone? Fanconi syndrome, it is your renal tubular acidosis. Very good, Jacob. Where you have damage in the proximal convoluted tubule. It's a type 2 renal tubular acidosis. That is what is nothing but your Fanconi syndrome. Okay. Now, coming to the clinical features that you will have in patients with membranous glomerulonephritis. Right. So the clinical features that these patients will have is some of them they remain asymptomatic, but those individuals whoever are symptomatic, what do they develop? They develop the frothy or the foamy urine will be there. The clinical features they completely vary. Either they are asymptomatic, right, or they may become edematous, and there will be presence of the frothy urine. And why is this frothy urine? That is because of the proteinuria. Okay. So now how will you differentiate the frothy urine in a normal urine sample and frothy urine when there is presence of albuminuria? How will you differentiate the frothy urine of a normal urine sample, and how will you differentiate the frothy urine of the, yeah, so you have to keep the sample for 5 minutes, and after 5 minutes if the froth clears, that is normal urine sample. If there is presence of froth even after 5 minutes, 15 minutes, that is suggestive of significant proteinuria. Okay, right. So these patients they will have edema and the frothy urine. The other important is you will have the presence of venous thrombosis. Why? Because these individuals they are at increased risk of dyslipidemias, right? And not only that, elderly individuals. So elderly individuals, okay. Can anyone tell me what is Virchow's triad? Yes. What is Virchow's triad? Very good. Endothelial dysfunction. Next, stasis of the blood, and then hypercoagulability. And then hypercoagulability. Okay. Right. So these are elderly individuals. So in elderly individuals, what will happen? There will be arteriosclerosis. Now, once there is arteriosclerosis, there will be stasis of the blood. Along with stasis, these patients they are having dyslipidemias, and that is the reason why the venous thrombosis is very very common, right? And this particular venous thrombosis, it can be in the lower limbs, that is in the form of deep vein thrombosis. Okay. Now, apart from that, these patients they will have signs or symptoms of an underlying infection or the neoplasm, because right, signs and symptoms of neoplasm. or infections, underlying infections and underlying neoplasms. Now you take this neoplasms. What did I tell you? There can be carcinoma of lung, carcinoma of the stomach. We have discussed now. You see this. So they can have the features of either neoplasm or they can have the features of underlying infection, whichever are causing that secondary membranous glomerulonephritis. And apart from these, okay, where all you'll have this edema. Initially, they'll have the puffy eyes, right? And followed by that, they progress to development of pedal edema. Okay, that is very important. And this frothy urine is what? This is due to proteinuria, right? This is what is your frothy urine. Now, these patients with membranous glomerulonephritis, they develop renal insufficiency. Right? They develop renal insufficiency. So because of the renal insufficiency, they will have hypertension. Okay. And because of the renal insufficiency, even the urine sample, if you observe, they will have abnormal urine sediment. Okay. These are the clinical features. And this thrombosis is not just seen only in the deep vein. There can be also renal vein thrombosis. And in fact, most common cause of renal vein thrombosis is membranous glomerulonephritis itself. So this is about the clinical features. Asymptomatic, or they may have edema, frothy urine, thrombosis, signs and symptoms suggestive of secondary membranous glomerulonephritis. There can be renal insufficiency, and because of renal insufficiency, there will be fluid overload causing hypertension. Coming to the workup. The workup, if you see, in these patients with membranous glomerulonephritis, one is urine microscopic examination. Urine microscopic examination will show the presence of the oval fat bodies, right? Oval fat bodies. Why? Because of your lipiduria and because of renal insufficiency, blood urea nitrogen, and as well as the serum creatinine levels, they are elevated, right? And you need to check for the anti-nuclear antibodies, right? Why? Because there are autoimmune conditions. So you need to test for that. And we need to check for the underlying infection, that is serology. So serology, you have to do for the HIV, then hepatitis B virus, and then the hepatitis C virus. This is what the serology you have to do. Then PET scan. Why is that you need to do PET scan? That is mainly to look for underlying malignancy responsible for the development of membranous glomerulonephritis, because we have seen some tumors also are responsible. And finally, what is the investigation of choice, which will definitely tell you that it is membranous glomerulonephritis. So investigation of choice will be kidney biopsy. So please remember, in all the forms of your nephrotic or nephritic syndromes, the investigation of choice will be the renal biopsy. And this renal biopsy, you have to observe that under light microscopy, electron microscopy, and then fluorescent microscopy. So you take the light microscopy. In or under the light microscopy, what is that you will observe is, you will observe that there is increased capillary wall thickness. Right, there is increased capillary wall thickness. And you will notice that this thickness, it is associated with the cellular proliferation. Right, associated with cellular proliferation. And the stain that we use here, it is silver methenamine stain. Right, the stain that we use is silver methenamine stain. And under this silver methenamine stain, that capillary wall thickness and cellular proliferation, how does it appear as? It will give you a classical spike and dome pattern. Right, you will have spike and dome pattern. Okay, so why are you getting this spike and dome pattern? The spike and dome pattern, it results from the subepithelial deposits. Right, it results from subepithelial deposits and as well as projections of the excess glomerular basement membrane. Your capillary membrane is getting thickened. So the thickened glomerular basement membrane, because of subepithelial deposits, there is projections. Right, projections of excess glomerular basement membrane. Okay, so this is about the light microscopic finding. Then what are the changes that you will observe in the electron microscopy? So in the electron microscopy, you will observe a discontinuous pattern of dense deposits. Right, discontinuous pattern of the dense deposits along subepithelial surface. Right, along the subepithelial surface. Okay, discontinuous pattern of dense deposits along the subepithelial surface of basement membrane. Okay, so that is what you will observe in the electron microscopy. Electron microscopy characteristic findings, you will be able to see or you will be able to visualize that subepithelial deposits. Whereas in light microscopy, you will have only that spike and dome pattern. Why are you getting that spike and dome pattern? That is because of subepithelial deposits. And this subepithelial deposits, they are observed under the electron microscopy. And fluorescent microscopy, that is immunofluorescence, you will notice that there's presence of IgG and C3. Okay, because the complement is activated and the antibodies are, the immune complexes are there. In that immune complexes, what you have is IgG. So that is about the renal biopsy picture, right? Then followed by that, how do you treat these patients? So if you see the treatment, important point, the diuretic, because these patients, they are having edema. So you need to give furosemide of low dose. And then for hypertension, you need to give AC inhibitors. That is for hypertension. And for dyslipidemia, you should give statins. That is for dyslipidemias. Okay. And as I have said you, these patients, they also have renal vein thrombosis. You see here, we have discussed that these patients, they're at increased risk of venous thrombosis, and there can be renal vein thrombosis also. So what is that you'll give for the renal vein thrombosis? For renal vein thrombosis, you need to give anticoagulants. Right? You need to give anticoagulants. Okay. And whenever there is renal vein thrombosis, what type of renal failure they will develop? Yesterday we were discussing. What type of renal failure these patients develop? That is post-renal type of acute renal failure. Right? They develop post-renal type of acute renal failure. So this is the conservative management. Right? Now, with this conservative treatment, almost 30% of patients, right, 30% of cases, they can have spontaneous remission. They don't require the immunosuppressive drug. Spontaneous remission may develop even in those with heavy proteinuria also, in almost 30% of cases. That is the reason why we don't give immunosuppressive agents immediately. Okay, so we give almost 6 months of, right, for those. So how many days we give this conservative treatment? Right, this conservative treatment is given for 6 months. But in spite of giving conservative treatment, if the patient's disorder is progressing, right, patients with nephrotic syndrome, despite 6 months of conservative management, and the serum creatinine is getting increased, then, right, so those individuals who have the progression of the disease in spite of conservative treatment, in them you need to give rituximab or corticosteroids. Right, corticosteroids or rituximab should be given. And these corticosteroids should be given along with cyclophosphamide. Right, so this corticosteroids and cyclophosphamide combination, you have to give for nearly around 6 months. 6 months. What are the other alternative drugs? The other alternative drugs are calcineurin inhibitors. Okay, and these calcineurin inhibitors should be given with or without steroids. And what will be that example of the calcineurin inhibitor? That is cyclosporin. That is cyclosporin. Okay, so this is a, and we have discussed that we have two forms, primary and as well as secondary. Primary is what the antibody is formed against your phospholipase A2 receptor, which is the antigen which is present on the glomerulus. The patients with primary membranous glomerulonephritis, these are excellent candidates for transplants. Right, they are the excellent candidates for transplantation. Okay, so this is about, and there are some patients in whom the prognosis may not be good. Now, who are those group of individuals where there can be poor outcome. So poor prognosis or the poor outcome is seen in the following group of patients, right? That includes number one, male gender. Next, elevated serum creatinine. Next, patient having hypertension. Patient having proteinuria of more than 10 grams per day, right? Then presence of or development of concomitant tubulointerstitial fibrosis. Right, concomitant tubulointerstitial fibrosis, right? And yeah, so these are the poor prognostic features. And if these are there, you have to and those patients who have developed end stage renal disease, in all of these individuals, the prognosis will be bad. That is about your membranous glomerulonephritis, right? So we are done with the topic of your nephrotic syndrome. So what is that we have discussed today? Minimal change disease, FSGS, and membranous glomerulonephritis. So I want you to answer quickly. I'll just revise by myself. So I'll just tell you, you listen. Biopsy is very, very important. Minimal change disease, focal segmental glomerulosclerosis, and then the membranous glomerulonephritis. Minimal change disease, light microscopy, there is no abnormality. Electron microscopy, you will have fusion of the food process, and that is due to loss of the proteoglycan, that is the heparan sulfate proteoglycan. And fluorescent microscopy, there is no IgG or C3. Then coming to your FSGS. In FSGS, you have to take the biopsy from deeper portions, right? Why? Because the lesions are present in the corticomedullary junction. So what will be the light microscopic finding in case of FSGS? You will notice that only few glomeruli, only the part of the glomerulus that is being sclerosed or fibrosed. Whereas you take in case of the electron microscopic finding, you will observe the presence of the hyaline deposits. And the fluorescent microscopy, you will have the presence of IgG. Then you take membranous glomerulonephritis. In membranous glomerulonephritis, in the light microscopy, the stain that we use is metheramine silver stain, and you have this characteristic spike and dome pattern. And in the electron microscopy, you will notice that there is presence of subepithelial deposits. And in fluorescent microscopy, you have the presence of IgG and as well as C3. Okay, so this was the biopsy picture. So biopsy is very, very important. Now, let me just try to quickly recap all this, what we have discussed today. So the first thing, like what we were discussing, is about the minimal change disease. So minimal change disease, as I have said you, it is the one which is most commonly seen in children. The proteinuria will be selective proteinuria, and it is predominantly the albuminuria, right? And you need to know the drugs. Okay, so minimal change disease associated with drugs such as NSAIDs, rifampicin, interferon alpha, ampicillin, trimethadone, toxins like mercury, then lithium, and bee sting, infections like infectious mononucleosis, and the tumors that will cause minimal change disease is Hodgkin's lymphoma. And these patients with minimal change disease, very important is the presentation will be in the form of the puffy eyes. They'll have this fluid overload that will progress to vulva or scrotum, and they also progress to pedal edema. And because of the fluid overload, there will be weight gain in these individuals. And because of proteinuria, there is decrease in albumin levels, and the fluid will try to accumulate in third spaces, like the pleural space, causing pleural effusion, because of which the individual will have dyspnea. And the fluid also will accumulate in the peritoneal cavity, resulting in ascites. And in these individuals, because of ascites, the abdominal girth increases and there will be everted umbilicus. And the blood pressure will be absolutely normal. And in the workup, please remember, blood urea nitrogen levels will be elevated, serum creatinine is elevated. Urine microscopy will show you the presence of the oval fat bodies, and 24-hour urinary protein levels are elevated, and C3 levels, they are normal. The kidney biopsy, as just now I was discussing, light microscopy, it is absolutely normal. Electron microscopy, you will have the fusion of the foot process, and that fusion of the foot process is mainly because of loss of basement membrane polyanion, that is heparan sulfate proteoglycan. Immunofluorescence, no abnormality. Drug of choice will be your prednisolone. You have to give totally for 8 weeks, and after 8 weeks, you need to taper and stop. Once they develop relapse, then we consider them as the steroid dependent nephrotic syndrome. So for them, we need to start the steroids again. But when you are giving steroids for long term, there is chance of development of Cushing's. So once there is toxicity with steroids, then you need to taper the steroids and start cyclophosphamide or levamisole. And as such, these patients, they have good prognosis. And in steroid resistant nephrotic syndrome, you need to give cyclophosphamide. That is about the minimal change disease. Now, at this point, one thing I just wanted to tell you is about the immune complex types. Right? Immune complex type of proliferative glomerulonephritis. So, you need to know the conditions where there is low C3 levels, and you need to know the conditions where there is normal C3 levels. Low C3 levels observed in idiopathic proliferative glomerulonephritis. Right? And low C3 levels also seen in post-streptococcal glomerulonephritis, also observed in lupus nephritis. In all these conditions, the complement is utilized. And even in case of cryoglobulinemia, the one which will occur secondary to hepatitis C infection. Then bacterial endocarditis, you can have this. And then these are the conditions where you have low C3. What are the conditions where you will have normal C3 levels? That is in patients with IgA nephropathy, right? Which is nothing but Berger's disease. Then Henon-Schollen's purpura. Then presence of the visceral abscess. That is not very important. But these two conditions, you will have normal C3 levels. So that is about the C3 in the fluorescent microscopy. C3 in fluorescent microscopy. Right. So what all we have revised now? We have revised the minimal change disease. Then you take the focal segmental glomerulosclerosis. I said you like it is mainly damage to the podocytes. And we have two forms, primary and as well as the secondary. Right. So you need we have primary and as well as the secondary. So primary, what did I tell you? It is mainly the problem in the podocyte protein, or the underlying type 4 collagen mutation is there, or the gene mutation is the APOL1 gene is being mutated. And secondary, like I said, infections like HIV, hepatitis B, and human parvovirus. Then the hypertension and massive obesity is another comorbidity. And drugs like heroin addiction and palmidronate. Then we have sickle cell disease. These are all the etiologies which will cause focal segmental glomerulosclerosis. And the clinical manifestations, they'll have hematuria, headache, non-selective proteinuria. 50% of them, they'll have renal insufficiency in next 6 to 8 years, dyslipidemia, and the prognosis is completely variable. And in the workup, the creatinine is raised. Urine microscopy will show that there is increased number of RBC. Biopsy has to be taken from deeper portions, that is from corticomedullary junction. Light microscopy will show you that only this already we have revised. the treatment. So treatment for all FSGS, they require diuretics, ACE inhibitors, right? Statins, niacin. And patients with primary FSGS, you need to give immunosuppressive drug, that is prednisolone should be given, right? And those individuals who are resistant to this prednisolone or intolerant, then calcineurin inhibitors and mycophenolate mofetil can be considered. And those individuals who are at risk of development of end-stage renal disease, in them, you need to give you need to do kidney transplantation. Prior to that, you need to do plasma exchange therapy and possibly rituximab should be given. And for secondary FSGS, you need to treat the underlying cause, right? So that is about your FSGS. Okay.